Hey everybody, welcome back to the Court of Random Opinion. My name is Lauren Neidigh. I wanted to give some insight into a case I've been seeing in the headlines a lot lately. Nick Reiner is accused of murdering his parents, Rob and Michele Reiner, and the internet has been full of people speculating about his reported schizophrenia diagnosis and what that might mean for his case. A lot of that conversation has been about why Nick wasn't institutionalized. Why wasn't he in a longer-term mental health facility? I worked in emergency psych for years, specifically on various crisis units or in the emergency department doing consults to help the ED physicians determine if psych patients need to be involuntarily hospitalized or if we could safely discharge them to a lower level of care. This often involved working with inmates who had been either arrested and were pending going to jail or who had been brought from the jail and were pending trial. I would sometimes consult on patients who told jail staff they were feeling suicidal or wanted to harm themselves or someone else. And in most cases, I would recommend discharge to the jail under suicide precautions. That's because not everyone with these symptoms or thoughts of self-harm needs to be hospitalized. There are mechanisms they can use within the institution, the jail, to manage that. So there are some symptoms that can be managed in the jail. You don't always have to send them to a psychiatric crisis unit. The jail puts them under special watch. They get checked on frequently for their safety, etc. According to recent reports, the mental health staff at the jail had evaluated Nick and determined that he was at risk for self-harm. He was then placed under the suicide watch until he's cleared by a doctor. Now, while this is something that can be managed, there's, issues that cannot be managed within the jail. So, for example, if there was some sort of debilitating hallucinations or psychosis that absolutely impaired this man's functioning and he couldn't take care of himself, that could have a much different outcome. And that would be an appropriate reason to take someone out of a jail and put them into a facility. So that's just a quick explainer on why he might not be in a facility right now. Now, of course, at the time I'm making this video, he's in the jail. So if something's changed, you'll have to let me know. But I want to discuss a little bit about why he may not have been institutionalized before the murders happened. And just to discuss these kinds of decisions and treatments generally, I think seeing the kinds of conversations and questions that are coming up now, there's just a lot that the general public doesn't know about what goes into having someone hospitalized and what kind of symptoms are appropriate for hospitalizations and why would someone with severe symptoms who is a risk of harm to themselves or to others, how could they get away with not being hospitalized? Why were they not kept for more care? Why were they out in the community like that? So before I discuss this further, here's a quick disclaimer. Nothing I say here should be taken as medical advice. I am not a doctor. I have a master's degree in criminology and a bachelor's degree in psychology with some additional grad school work in forensic psych, but I've never been a therapist, never prescribed medications. Those are very different roles. Most of the rest of my immediate family are licensed psychologists or therapists, so I've had a lot of exposure to this stuff from a young age, but my job has involved a much more specific and narrow scope. I don't work physically in the hospital anymore. I've moved to a remote role, but I did that work on the ground for several years. My hope is that in discussing some of this stuff, I can also help people get a better understanding of issues in psychiatric care that are facing the country at large. Since this video is just going to be me sitting here talking, I'll probably turn the face cam off so you can just listen to this one if you don't want to stare at the screen. I'll put timestamps in as well if you want to skip around to specific topics. So just to give some brief background on what we're talking about here, there are widespread reports online that say Nick Reiner was diagnosed with schizophrenia and had recently been treated at a rehab center that specializes in mental illness and substance abuse. Prior to the murder of Rob and Michele, Nick had been behaving in a way that was described as extreme and stressful. He attended a party where others described him as bizarre, and he made people feel uncomfortable. According to reports, Nick's doctors had recently adjusted his medications, and this had not been having the desired effect. The family has asked that speculation be tempered with compassion and humanity, and I intend to do that, so I'm not going to talk much about Nick's issue with his family or his background. I'm going to speak more broadly about someone with the condition of schizophrenia and how Nick's specific situation may apply. I'm going to tell you why someone who reportedly suffers from schizophrenia and substance abuse disorders might not have been held in a hospital. I want to discuss why that's a problem and what could lead to someone being released prematurely or even not getting the help in the first place before it's too late. Oftentimes, people with symptoms of schizophrenia or thoughts of self-harm may be deemed inappropriate for an inpatient unit. It happens a lot more than people think, and sometimes our system gets it wrong with dire consequences. One of the major issues in this specific case is the co-occurring drug use. A lot of the general public who don't deal with people who have mental illness often have this perception that people with schizophrenia belong locked away in a padded room. For the most part, that's not true at all, but there are a number of reasons why someone who needed more restrictive care might not get it. So Nick reportedly has a long-standing co-occurring substance use disorder. Some drug use can increase the risk of developing schizophrenia, but drug use will almost certainly exacerbate the issues. It is possible that his substance use was a factor that led to him not getting the proper help because he could have minimized his symptoms while not using the substances and attributed those symptoms strictly to the drug use. Like somebody could act out and say, oh, I was just high, and then they appear to be acting much more normal since the drugs have left their system, but it doesn't necessarily mean there wasn't an underlying issue. Now, how much of a factor drug use might play can depend on where you live. I live in Florida, so where I live and where I worked, intoxication is an exclusionary criteria under the law, so you cannot hospitalize someone based on behaviors that occurred in the context of substance use. In theory, that makes sense. In practice, it's often ignored. It was one of my biggest pet peeves on my job, but in this case, there's a potential for drug use to muddy the waters. When a patient with schizophrenia who also uses drugs comes in for evaluation and treatment or is brought in by the police or against their will somehow, their initial presentation is generally much different and even more aggressive than when the drugs have been washed out of their system. We can't indefinitely hold patients against their will. It's appropriate to give people the least restrictive care possible, provided that the patient is not at risk in doing so. So when evaluating whether or not somebody needs to be admitted, you need to be very careful with making that decision because you're taking away someone's freedom. It's absolutely necessary, but still, it's not something you want to do to somebody who doesn't actually need it. So when a doctor who has a patient who comes in aggressive and psychotic, but they were on drugs and they have a longstanding history of drug use, there are going to be situations where after the patient becomes sober, if the drugs have washed out of their system, the doctor will release them because they're no longer a danger to themselves. If they're not an acute and active, serious danger to themselves or others, we have to let them go. So speaking generally, if someone like Nick was using drugs while the inappropriate or bizarre behavior was occurring, it could have been written off as a product of the drug use. When the drugs leave a patient's symptoms, they can act in a more controlled manner a lot of the time. They might be able to minimize their issues and their symptoms when they're speaking to a caregiver or an evaluator or a doctor in order to avoid inpatient placement. Sometimes the opposite is true. When a patient dishonestly denies drug use and refuses consent to a drug test and you don't have any background on them, it's often appropriate to proceed with caution and having them evaluated by a psychiatrist. That's for the safety of the patient and those around them. So we have the issue of patients who actually need treatment not getting it because it's written off as just a drug issue. And we have patients who do not need the treatment and do not want to be held against their will, who unfortunately are because they don't want to tell the truth about their drug use. And so we have to assume that it was a mental health issue. Another issue that's come up was with the medication change. So there are several things that can go wrong with medication changes. Like I said, Nick, his doctors reportedly changed his medications 3 to 4 weeks prior to the murders. And even if someone is taking medications, it doesn't necessarily mean that the medications are going to have the intended effect, especially if that person is also abusing substances. Drugs can completely nullify any positive effect of the medications. They can actually take negative side effects and make them infinitely worse. But there are issues even without substance use at play. So there are so many different medications and combinations of medications that can be used to treat schizophrenia or schizoaffective disorder, which schizoaffective disorder, it's like schizophrenia, but with a more prominent mood component. A medication change in itself can lead to worsened symptoms. So medication side effects are different by individual. And this is true even with something like depressive disorder. So even if we're not talking about somebody who is schizophrenic, it's like if somebody's depressed and they're having thoughts of self-harm, some medications can make that worse. So it can lead to tragic consequences if the patient is not properly supervised. Now, most people who have mental health issues can be supervised on a regular outpatient basis. So they go see their doctor once a month for maintenance. And if medications need to be changed, they can do that at the outpatient appointment. If the patient reports like a severe negative side effect, they're often encouraged to go to the hospital. So where possible, medication changes happen outside of the hospital. But if a patient's in a truly decompensated state, admission to a psychiatric crisis unit for supervision can be appropriate. Even if they've seen a doctor and their medications have been adjusted, it doesn't rule out the need for a more hands-on intervention. This allows qualified physicians to monitor the side effects of any new medications or medication adjustments. Personally, I would always have a loved one evaluated if I notice an escalation in perceived symptoms or strange behavior, because as heartbreaking as it is, a patient can do everything right and still have everything go wrong. Now, again, I'm just speaking generally. It sounds like Nick was not that receptive to a lot of help from what I can tell, what I've read, but we'll get more into that in a second. There's an issue with treatment and placement itself. Our hospitals are, for the most part, they're not set up for the kind of care that patients with severe mental health crises need. There are some facilities who can take on patients for longer periods of time, but these are usually private or specialized facilities that most people don't have access to. This particular issue might not apply as much to someone like Nick, who had a wealthy family, but from what I can tell, it sounds like he did not want to take the treatment seriously and very likely refused that kind of help. If the person in question refuses to get help voluntarily, you have to go through the systems in place to have them involuntarily admitted, but this is not guaranteed to result in placement. I just want to emphasize that his family could have done everything possible and still not been able to get him the help he needed because of the issues with our institutions, which I'll discuss a bit further. In most hospitals, the psych ward, as people call it, is a crisis stabilization unit. This is a short-term solution with rare exception. So for the most part, people who are brought to the hospital or the emergency room in a psychiatric crisis state are treated with a broad brush. So if you're dealing with a patient who came in for a self-harming episode or an episode of psychosis, the immediate goal is going to be the same. Determine the level of care needed, which in this hypothetical is going to be an involuntary admission. Then in the psychiatric unit, the goal is to stabilize the patient to their baseline. This means the patient is discharged once they've reached their baseline level of functioning. Because a crisis stabilization unit is meant to be a short-term emergency treatment, and the patient has to seek continued care in the community to maintain their baseline functioning. So even if they have long-term symptoms that affect their quality of life, this is something that is, the way our system is built, that's meant to be treated in the community. So these crisis stabilization unit admissions to the hospital, they most often last 72 hours or less. It can be longer. Sometimes it's 5 days, sometimes it's a week, but that's not really long term. It's very rare to be there longer than that, at least where I've lived and worked. One of the most common causes of recurrent admissions is that people don't keep up with their appointments or their medications in the community, and then they're returning in a state of perceived crisis over and over again. And oftentimes they relapse with substance abuse, which worsens the situation. They become institutionalized by this cycle, which only makes it more and more difficult to create a consistent and stable lifestyle outside of the unit. Because of this, the patient's history and baseline functioning become a major factor in whether or not someone is admitted to the unit. We sometimes have patients waiting days in the emergency room because the area mental health hospitals are full, and we cannot move them until a bed becomes available. We have a serious crisis of mental health, and necessary treatments are not accessible to the people who need them. A lot of the accessibility issues are made worse, at least where I've lived and worked, by widespread homelessness and substance abuse. We would have patients who were hopping from hospital to hospital around the city seeking admissions for mental health issues because they had become accustomed to using it as a means of survival. Because of the lack of resources for the homeless and those who really needed substance abuse rehab but couldn't or wouldn't get it, psychiatric crisis units were overflowing with patients whose true issues could not be solved by a 72-hour stay. For example, if I'm holding you involuntarily for 72 hours, that's not going to solve your homelessness, especially if it's somebody who is continuously readmitted and refuses to use the resources that are given to them as far as like shelters and housing placement goes. It just becomes this seemingly unbreakable cycle. And then the patients who really needed emergent treatment were either turned away from community health centers in the area because they were full, or they sat against their will in an extremely stressful emergency room environment, waiting for placement for hours or days at a time before being moved to the psychiatric unit and seeing a psychiatrist, which only made their crisis feel infinitely worse. That discourages people from seeking help in the future. We do have state hospitals that house patients who need longer-term care due to incompetency or inability to care for themselves, but this is for people with severe, persistent mental illness who can't function on their own at all, and they often need to be restored to competency before they can stand trial. They have extremely long waiting lists for the state hospital, and the area crisis facilities have to care for some of these individuals until a bed opens up at the state facility. It's important to note that the patients in question have to be truly disabled by their mental illness. So many people, unfortunately, make choices not to take their medications or care for themselves, and they do so consciously. They don't take their mental health care seriously. They don't want to, and they have the right and the mental capacity to make a decision to refuse help. It's really hard, especially for their families, because there's really nothing you can do. If the person has the capacity to make that decision, you can't force it on them. And a lot of these people unfortunately end up in jail because the persistent bad and strange behavior, it continues with no real way for any of their loved ones to do anything about it. So people exercising their rights to make that decision to decline help, that's not the same as someone who truly cannot understand and perform their basic needs. The crisis unit has to house patients like that until they can be transferred to the state hospital, which leaves fewer available beds for patients in an acute or shorter term crisis, like an immediate crisis. So this is why baseline becomes such a big issue and it comes into play so much. I can't speak to Nick's baseline or his symptoms here. I mean, I've seen the videos going around and stuff from past behavior, but again, it's very difficult to determine what's a product of someone's drug use and what's a product of their mental health disorder, especially if you don't know them, like you're really not supposed to do that. So I won't speculate on the cause of those behaviors. I have seen them, but I can't speak to what his like normal everyday baseline is. So I'm just talking about general mental health treatment. We have to be careful in our decisions to admit someone or not. Think about it like this. If somebody is truly telling you like, I'm not like hearing voices or I'm not suicidal, and like the officer who brought them in wrote on the paperwork that they were, he endorsed those things and they signed off on it and they put him in cuffs and they brought him to the hospital, and the patient's trying to tell you, no, that's not true. And it's really not true. If we get that wrong, you can traumatize somebody by holding them against their will, forcing them onto a unit, taking their rights and freedoms away, and they're surrounded by sick people who may put them in a vulnerable position where they could even get hurt. It's hardly unheard of for patients on a psych unit to hurt each other or hurt the staff. So you can traumatize somebody by admitting them against their will when it wasn't necessary. I mean, I've had times where officers came in with paperwork that was lazily done and said things that were not necessarily true. Because I had spoken to the patient and their family member and everyone confirmed, hey, that's not exactly what happened. And the officer explains, oh, well, I just wrote it that way because, and I would have to stop them and say, no, you write it exactly how it happened. Otherwise, you open us up to doing some serious damage to somebody who absolutely did not need this. And I can't really give more specific examples than that because I like to be kind of careful where I can when it comes to like talking about my job specifically. I don't want anyone to ever be identified from anything that I say, HIPAA laws and all that. So for all I know, that person could be out there telling their story on Instagram. So if I gave you any specifics and anyone ever came across that, that would be a problem, right? So I can only say so much, but hopefully what I'm saying makes sense. So we have to be careful with that, not only because if you don't admit someone who needs to be admitted, they can get hurt, but also because you can really hurt someone who gets admitted that doesn't need to be. So one of the things that factors into that is if a patient has a known and longstanding history of something like schizophrenia and presents with psychotic symptoms, they have to be assessed for severity. So if someone like Nick went into the hospital or was brought into the hospital against their will, you would need to understand the nature of the symptoms to know if it warranted hospitalization. And again, I'm going to start speaking generally here. A lot of people who only know basic things about schizophrenia understand that sometimes people hear voices. So that's what I'm going to use as an example. If a patient says they hear voices, that in itself is not enough to have them involuntarily admitted. I would have to dig into that a little bit, dig into the nature of it. Are they commands? Is this something new? Do these voices tell you what to do or encourage you to harm? Do they arise in certain situations? Are you experiencing this right now? And then you have to pay attention to whether or not they're actually responding to some sort of internal stimuli. Because for some patients who suffer from psychosis, if they experience auditory hallucinations on a regular basis while they're at baseline, but they know that it's not normal to have hallucinations and they're capable of seeking the appropriate help, those people can most often be treated at the outpatient level. This is not always the case. Again, you should not take this as medical advice. I'm just giving you some insight into what I've seen on a regular basis. So patients who are maintaining their care and not a danger to themselves or others should not be forced into an involuntary stay against their will. That, again, just discourages people from seeking help in the future. The patient needs to have a level of trust that a doctor will not go to unnecessary lengths if it isn't absolutely needed. But then this unfortunately opens up to the possibility that someone who needs to be institutionalized falls through the cracks and they may hurt someone. So I've been hearing a lot about Nick Reiner and his diagnosis and why people think that he wasn't institutionalized. And a lot of that could have to do with the substance abuse, yes, but there's also some mental health stuff that could be contributing. And when our doctors and psychiatric staff make decisions like this, they have to understand that harm can be done if they make the wrong decision one way or the other. Oftentimes it's best to proceed with caution. I certainly did a lot of times when I was making my recommendations to our ER doctors as to whether or not they wanted to admit somebody, but it's not always possible. There's just so much that can go wrong because of the way our systems are set up. And some people have the privilege of access to private institutions that will give you longer term care, but most people will never have that kind of access. So most people only have access to these short-term crisis facilities or the longer-term facilities that are only for patients with severe and persistent disabling mental illness. We don't really have much of a middle ground, and I think there needs to be one. So, all right. I hope this helped give some insight into how mental health systems work in general. There's one more thing I'd like to add. There's a reason I wanted to be clear about my background in education earlier in this video. When you're looking at cases like this on the internet, especially those that generate a lot of public interest and therefore a lot of revenue, it's important to pay close attention to the source you're getting it from. Licensed professionals in the fields of psychology or psychiatry cannot diagnose public figures or people who aren't their patients. They cannot give a definitive diagnosis or an answer to what happened or why. They can only speculate. So if you see someone online who claims to be a doctor but is speaking in absolute certainty, they're not operating by the ethical standards of the profession. One example of a professional that I do like, who I feel like toes that line appropriately, is Dr. Grande, who's informative and interesting while not doing anything unethical. So he's got some interesting stuff if you want to go listen to him. All right, guys, that's all I got for you now, but thanks for watching, and I will see you all soon. Don't forget to hit the like on this video. I post links to my social media in the comments. I'll pin it, and I'll catch you next time. Thanks.